Welcome to the Healthier Pregnancy Presentation Series. I'm here with Dr. Sharon Phelan from the University of New Mexico School of Medicine, Department of Obstetrics and Gynecology, to discuss the Affordable Care Act covered preventive service of tobacco use counseling. Thank you for taking the time today to come out and provide us with more information on this very important topic.
Well, thank you for asking me.
Yes, and today we're going to be discussing the screening process, interventions, counseling, and/or referral processes for tobacco, specific to pre- and perinatal patients. So let's start by just learning a little bit more about your background.
Well, I'm a general OB/GYN. I'm vice chair for patient safety at the University of New Mexico and the medical director for both labor and delivery and our outreach clinic system called Maternity and Family Planning. And I've been an obstetrician for about 30-some years.
Okay, great. So in your very rich experience then, can you tell us why you think it's so critical that providers offer screening for tobacco use to all of their pre- and perinatal patients?
Well, as no big surprise, smoking kills. It's one of the major reasons for cancer. Women are fearful of breast cancer, but actually lung cancer kills more women than breast cancer. It causes a number of problems during pregnancy. Most of them, as the slide shows, are related more to growth restriction on the baby's part. Growth restriction leads to increased chances as they get older of heart disease, obesity, diabetes. It also causes preterm deliveries, SIDS, and other really preventable complications of pregnancy.
Do you think that most women are aware of those complications?
I think most women are aware that they shouldn't smoke. I'm not sure they're aware of the exact problems, and particularly the long-term problems for children. Women who smoke who are carrying a female fetus, the likelihood of that young girl taking up smoking is much greater than if her mother had not smoked. And we don't know why, but it seems that there gets to be some hard wiring of the brain.
Okay, so there's a lot of interesting information that women may not have. And actually one of the areas is, what about, emerging delivery systems? What's the safety of those products?
They are not safe.
Okay, so can you tell us more about what products you're talking about?
The most common one is going to be the e-cigarettes.
Okay.
And I have a couple slides on e-cigarettes that are probably showing right now. But these are electronic cigarettes that carry what they call the juice, which is the nicotine-containing, often flavored product that then is heated by a battery, and then you inhale the water vapor. These have nicotine. They are unregulated. The amount of nicotine is unknown, and it is probably the nicotine that creates the biggest problems for the pregnancy. They do avoid the smoke, so in that way they may be slightly less harmful than actual cigarettes. The other modes are chew, such as snus. You can have hookahs, which tend to be more group smoking. The cigarettes, the little cigars are an alternative that more and more women are using. So all of these are nicotine delivery systems. Many of them are thought to be used to bypass a number of the current regulations that people have put in place to try to encourage folks or make it more difficult for folks to smoke and aid them in quitting, such as the Clean Air Act. And I have a slide that shows the map with the Clean Air Act. Taxation. E-cigarettes are not taxed, so they tend to be much cheaper. Laws regarding who can purchase. And there are no, except by states, laws regarding age of which a person can purchase e-cigarettes. So these are now being marketed to teenagers and are clearly a gateway into cigarette smoking. So all of these are new products, but they carry the same risks as the more traditional smoking.
So clearly there's a lot of education that needs to take place both with women and providers about some of the risks of smoking for pre and perinatal women.
Yes, I think many providers have fallen into the trap of saying the electronic modalities are safer than cigarettes. And I worry about the use of the word safer because the women hear safe. And I think they should be listed as perhaps less harmful because they are still harmful. Nicotine is a D category drug.
So, well, when we're talking then about within clinical practice, how do you screen for tobacco use? What kinds of questions do you ask? Do you ask it as a self-report? Should the clinicians be asking? Can you tell us more?
Well, the key is everyone should be asked.
Okay.
Some people say you should look at more risk factors and then screen based on risk factors like many other screening modalities. The thing is that women smoke for such a variety of reasons, you can't really screen for that. Some women will do it for weight loss, some will do it because it's glamorous, it's sophisticated, it's rebellious. But some women do it quite honestly, I feel, because of depression, low self-esteem, these types of things. And if you look at the traditional risk factors for smoking, many of them are things such as low education, single parenthood, women of color, these types of issues, which are clearly quite stressful.
Sure.
And so those women, I think, are using it for self-medication. It's a legal and, on the long run, more expensive way of medicating their depression, their post-traumatic stress disorder, dealing with their domestic violence, whatever. With that, those reasons, I personally feel, though I'm not aware of any research, that many of the women who are doing it for more social kinds of things, the being part of the group, the weight loss, the glamorous, are often self-quitters.
Okay.
So they will start the pregnancy, they know they shouldn't smoke, they may not be addicted or dependent on it, and so will quit. When they come in, if you were to just ask, oh, you don't smoke, do you, now that you're pregnant? They'll say, oh, no.
Okay.
Even though their last cigarette may have been that morning, they're now motivated to quit. So you'll miss a great number of the people who do smoke. So that's one reason why the National Cancer Institute, in their 5A screening program, recommend that the first A, which is ask, be done in a standardized fashion.
Okay.
I have a slide that lists the questions that they recommend rather than the easy, you don't smoke, do you, question, which will not, the answer is about as worth as much as the
always
question.
Going to be no if you ask it like that.
Oh, yes. Even though they reek of tobacco smoke. And if you look at this list, it does give the patient, well, let me back up. The way to do it is to have it written out on a card or something if your population is literate and able to read the card or have it in their language. If not, someone should read it to them.
Okay.
But it gives you the options from I've never smoked, I've smoked fewer than 100 cigarettes in my entire life, to I recently quit, I've cut down since I found out I was smoking, or I'm continuing to smoke the same.
So the patient's filling that out on their own?
Right.
Okay.
And they choose which is best. This allows you, if someone has never smoked, then you probably don't need to invest much time in the issue other than perhaps secondhand smoke.
Okay.
If they've recently quit, they would have answered the do you smoke question with no, but those are people who are very vulnerable during the stresses of pregnancy, possibly to relapse. And if you've never asked or found that out, you won't ask.
Sure.
The other folks are more obvious that they are going to need help to continue to quit, cut down on their cigarettes or quit altogether, ideally.
In addition to asking, then, what else goes into that screening process?
Well, when you find out that they are indeed, if they're a non-smoker, praise them. If they have a recent quitter, praise them, but also say, let me know if you run into difficulties so I can continue to help.
Good point.
If they are continued smokers, then you need to advise and assist, go through the remainder of the A's.
Okay.
One of the things I will do is say smoking is not healthy, and it is dangerous for your baby, both while you're pregnant and afterwards, and will encourage them to consider quitting. If I can personalize it by, I know your other child has asthma, or things of this nature, that makes it more relevant. It's also nice to ask the patient, what does she think about her smoking? Because you'll often find out that she's quite upset about it, but she has tried repeatedly to quit and is unable to quit, and is now does not have the emotional energy to set herself up for, as she puts it, failure again. So doing those kinds of exploration with advising and assisting is useful.
And does that happen all at one appointment, or then do you refer people on for some sort of a larger intervention?
Well, this is one of the big issues, are barriers to this whole screening and treatment. If you go through all of the 5 A's, you should be able to do those, and the slide refers to them, supposedly in 3 to 5 minutes.
Okay.
It probably takes a bit longer than that, but time is becoming tighter and tighter with all the other counseling OBs have to do, particularly at the first visit, regarding genetic screening, diabetes screening, domestic violence screening. I can go on and on and on. What happens in many places is if they get a positive screen for smoking, they may advise or make some comments to the need to try to quit. And I do think those are important to come from the physician or the midwife or the obstetrical provider, because that carries some weight. But I'm not sure the rest of it all needs to come from someone at that level. And often it may be better to come from some supportive person in the office, or even refer out, that is maybe a little less intimidating than the physician in their white coat, or has more time to sit and talk with a woman and problem solve and try to get more to the root of her use. So in that way, we often talk to ask, advise, and then refer for another resource, be it the 1-800-QUIT line, your hospital program, potentially someone within your group practice, if you have a large enough group practice, who's sort of a born-again non-smoker who takes this on with a passion to help these women.
You said something very interesting earlier in the conversation about how sometimes there are women that smoke socially, and you may see them prenatally or perinatally, and then there's women that might be going through things that are extremely stressful in their lives, or maybe you mentioned domestic violence. Like, are those women, are there things that obstetric providers should know in terms of treating those women differently? Or, what do you think the take-home message is on that one?
I think they do need to be treated differently. If everyone could be treated the same, we wouldn't be having this discussion, because there'd be a canned approach to smoking cessation, and everyone would know it. This, like many behaviors that have multifaceted reasons, you need to be sensitive to the woman's background and why she thinks she may smoke, or why she's had troubles quitting smoking if she's tried, and tailor your approach to acknowledge those issues. It's kind of like treating an infection. If it's a low-grade viral bug, then you might be able to just give Tylenol for the aches and the fever and let the body take care of it. So, but if it's a bad sepsis, you've got to give antibiotics too, not just the Tylenol or the aspirin. And that goes the same here. I think if someone is dealing with smoking and is using it, it appears to be a self-medication for depression or domestic violence, you need to get to the roots of the problem. You need to consider an antidepressant along with your nicotine replacement. You may need to consider getting them into a safe home or domestic violence counseling. So it's not as simple as just telling people to quit and maybe giving them some nicotine resources.
Yeah.
You've got to get to the basis.
Which kind of leads us to the next question is, what do you think the biggest obstacle is in implementing routine screening for tobacco use and nicotine?
The screening isn't as much of a problem. It's screening properly.
Okay.
Because I think when you talk to folks, everyone asks, do you smoke? But it's the screen where you get more information, and then it's the follow-through. People don't like to ask questions, particularly healthcare providers, where if they get a positive answer, they have nothing that they can offer the patient to help them. It's like kind of opening a wound and then just saying, oh, well, I'm sorry about that, and keep on going.
Sure.
So I think time is a big issue. And then I believe resources, the provider feeling that they have the resources either within their practice or within the community to get the patient the help that they are interested in getting.
So if either hospitals or clinics or individual providers are looking at this saying, well, how can we overcome some of those obstacles? Do you have any suggestions for that?
I think one of the things the physician or the healthcare provider need to do, and I keep using the term healthcare provider because there are a lot of midwives out there and who are providing, and nurse practitioners providing prenatal care and obstetrical care. But I think they need to become somewhat active within their community system and talk. Many hospitals have the resources and interest in providing smoking cessation programs, particularly to non-pregnant people. So they may need to work with those groups to help them feel more comfortable in providing the services to pregnant women. They should talk to their March of Dimes organization, their health department, and try to come up with collaboratives providing these services, advertising these services, those types. You need to become an activist, back like the 60s and 70s.
That's great. I mean, that's great. And I think so you're pointing to a lot of very specific resources that people can tap into. Are there other things that you think the healthcare system can do to support this type of service? Yes.
There's the web. The web's incredible.
Okay.
You can get into the .gov area, the cdc.gov. There's all sorts of information there, both from a medical perspective, a patient perspective, and resources.
Okay.
There is also March of Dimes has information. There's Smoke-Free Families. And then there's one that you can get through the cdc.gov or through the American College of OBGYN.org that was done through Dartmouth. And it's a virtual clinic on smoking cessation. And there should be a slide that references that. And this gives you the opportunity to go through a series of clinical vignettes with actors where you can ask a question and they will respond to the question you asked. Well, you're given a kind of a choice. It's a little more rigid. But they're very realistic as far as the response the actresses give. Or in one case, there's a couple. There's also all sorts of resources on there. Dr. Coop has a talk in there. And it's good not only for the providers, but even the support staff can see how they could ask a question and how it might be misinterpreted by the patient and the response they might get, which is unintended. There are CME credits given for it if that's important for either nursing staff or physician staff.
Well, that's great. So it's great to know that there's a lot of educational resources out there, but there's also some interactive resources where people can kind of practice, because I think you're right. Sometimes people wonder, what do I say or how do I handle it if a patient says this or that? And that sounds like there's some wonderful resources.
Now, there's one area we haven't talked on that I would like to bring up, and that is pharmaceuticals. We sort of alluded to it when we were talking about depression and those types of things. It is clear that in the non-pregnant woman or non-pregnant smokers, that nicotine replacement along with counseling are major players in successful smoking cessation.
Yes.
Counseling by itself works, nicotine replacement by itself works, but the two together work much better. The problem is in pregnancy, it is not as clear that they work as well. And part of that is, I think, the variety of reasons why women are continuing to smoke when pregnant. Nicotine replacement is something, though, that should be considered in your heavier smokers.
Okay.
I think one of our big problems with nicotine replacement is we tend to often give lower doses because we don't like to use nicotine when someone's pregnant.
Sure.
But we may be underdosing them, which is setting them up for failure. So you need to be sensitive in what they need. They may need both a patch and gum. When a woman asks if she can use e-cigarettes, I discourage that because I don't know how much nicotine is in the e-cigarette, and it is not set up for a stepwise reduction in the amount of nicotine you're getting.
Yeah.
So those work. You've also got Chantix and Wellbutrin. Wellbutrin, I'm intrigued with, although there's some push not to use it postpartum because of it's also an antidepressant. And I feel that the antidepressant additional may be useful for these women who are using nicotine as a self-medication. So I would encourage folks to not discount pharmaceutical intervention, realize that it does have some negatives, but much like the e-cigarettes, it is much less harmful than smoking. It avoids the smoke, it's regulated, and you can have a step-down process, as well as antidepressants and counseling.
Okay.
One other thing we didn't mention, I forgot to mention too, was with the e-cigarettes, one of the big dangers with them that most folks don't realize is when the little vial with the juice is very concentrated nicotine. The number of poisonings that are of children coming into ERs because the juice comes in a little bottle that is not safety sealed and smells like apple or grape or something good, and kids are drinking it. I'm not aware of any deaths yet, but there's been that. And that people will fall asleep smoking these because they're not going to set the mattress on fire. But if the little vial breaks, it's absorbed through the skin. So you can get nicotine poisoning. Even filling the container, if you're not careful, can get nicotine poisoning. And that's another hidden risk that many people are unaware of.
So there's a lot of education that needs to take place about this, clearly. Yeah, and I think you've really done a great job of getting providers to consider, you know, the different issues involved with perinatal, you know, women and what might be going on and the different types of smokers. Are there any other, you know, what are the take-home points you think that you want people to think about today?
Ask everyone if they smoke or if they're around smokers, because secondhand smoke is an issue also. Realize that not all smokers are the same. The reason for them smoking, the support systems that they have at home to quit smoking, their work environment are all very different. And become an activist. Get involved. How to help your patients. It may help them stop smoking. It may help them stop drinking, drugs, any number of behavioral things that I think more and more people are becoming dependent upon in our stressful environment. And the traumas that many women have experienced, they've resorted to these. So become an activist.
Great points. Thank you so much for joining us.
Oh, and certainly. Thank you for asking me.
Sharing this great information.